So you're very welcome to this, another one of our themed China episodes supported by our gold partners, Bayer China. I'm here with our China editor, Yao Zhu. Hey, Yao, how are you?
How are you, Declan? So it's really nice to have you cast in mainland of China in Shanghai.
We are in mainland China today, and I'm here in Shanghai. We're at the periphery of the big geo-oncology conference that we showed you some conference highlights on a few weeks back. But we have a proper themed episode today, kind of at the start of 2025, looking forward to changes in geo-oncology, prostate cancer in particular, here in China. And you've invited along a couple of local guests here from China to talk to us. Do you want to introduce our friends?
Yeah, so we are great to have Dr. Zeng Hao from the Huaxi University, and we are great to have Dr. Yan Ye from the Beijing University. So can you briefly introduce yourself?
Yeah. Hello, everyone. I'm Dr. Zeng Hao from West China Hospital. I'm a urologist.
Yes.
Hello, everyone. I'm Yan Ye from Peking University Third Hospital, and I'm a urologist too.
Great. Well, welcome, and thank you very much for joining us. So I suppose there's been a lot of changes in prostate cancer over the past few years for us urologists. Everything from metastatic hormone-sensitive big changes, imaging in prostate cancer, diagnosing patients, MRI, biopsies, PSMA PET. There's a whole plethora of changes. So we wanted to sort of consider what the situation is like here in China, with all of these areas. Maybe we'll start early. Let's start with, how do you diagnose prostate cancer here in China? What sort of patients? What's the proportion of metastatic disease? And then do patients go straight to a biopsy? What type of biopsy? What's the role of MRI? Yeah, let's take the guests through this.
Yeah, so as you have mentioned, that China is we have an increased incidence of prostate cancer, and we have many novel technologies like the MRI scan and the PSMA. So it's really nice to see these changes in our clinical practice, and we would love to hear the opinions from our guests about how to incorporate like MRI and the PSMA in your clinical practice to increase diagnostic accuracy for patients with prostate disease. So please.
Yeah. Right now, in our hospital, we just summarized our biopsy cases for the past 10 years. And in the past 10 years, just like Dr. Zhu Yao said, there are so many innovation in the prostate cancer biopsy or diagnosis. And maybe before 10 years ago, we used systemic biopsy for the prostate cancer patient. But now from 2015 in our hospital, we initiated with a target therapy with multiple pyramid MRI. And after we use the target combined with the systemic biopsy, our detection rate increased from 26% to 40%.
Wow.
So that's a very great improvement. Yeah.
2015 was very early. I'm just thinking, because I'm thinking in Australia, we were using a little bit of MR, but that was before the precision trial and all that came out. But everyone knew MR was good. But so that's a very interesting experience. And I think to remember that when it introduced, something changed, didn't it? And it improved your accuracy.
Yeah. As you know, because our hospital is just located in the southwest of the China, and maybe at that region, the patient may be a relative advanced
cancer.
Advanced cancer. So maybe before 10 years ago, there's a lot of metastatic patient, and what I say 26% is just for the localized prostate cancer patients. So
these are not the patients turning up with pain in their bones and so on.
Yeah.
So how about Dr. Yan?
Hi. So China is very big. North China and South China and West China. I'm come from North China. So the situation at our hospital is a little bit different from Dr. Zeng's hospital. So we are still doing systemic biopsy now, and we use multiparametric MRI to do cognitive fusion biopsy for the suspected lesions. So our detection rate is about at 40%. We do about 800 to 1,000 biopsy per year.
Okay.
So So, Declan, we have some experience from the study performed in PTMAC, like the primary trial.
Yeah.
They are using the PSMA PET imaging to cooperate with MRI to increase the detection rate for prostate cancer. And nowadays in our center, we have some patients with PIRAS 3 and the negative first biopsy disease. We will refer the patients, if his PSA is still increased, we'll refer the patients to the PSMA PET imaging. So how about your recommendation to those patients, MRI PIRAS 3 or 4, the first biopsy is negative, and how to treat these kind of patients?
Yeah, look, that's a really interesting topic, isn't it? So I think I hear from you that as much as you can, everyone's embracing MR before a biopsy, but we still don't fully trust MR, do we? And especially if it's normal and the patient's had a negative biopsy, but the PSA is 15 or 20 now. So yeah, PSMA PET is interesting in that space. We did publish a trial called the primary trial, showing if you add in a PSMA PET, it did increase negative predictive value. But that has led to another trial called the Primary 2 trial. So in Primary 2, which is led by my colleague Daniel Moon, who's a urologist, he's the urology lead on it, along with Michael Hoffman and Louise Emmett, a nuclear medicine specialist. It's a randomized trial. So it's patients who have a normal MR or equivocal, PIRADS 2, 3, but a red flag, like the PSA density is high. So they're the sort of patients we would traditionally do a systematic biopsy on because we don't trust it. So in this trial, if the PET scan is normal, we don't do a biopsy. So you've got double negative imaging. And that was based on the primary trial. We showed with double negative imaging, the negative predictive value is more than 91%. Whereas if there's a target on the PET scan, we just do a targeted biopsy of that area. So that trial is 650 patients and it's about 3/4 recruited. So we won't have the answer this year. We will have it soon though. So what do we do in the meantime? We try and put them on the trial. Sometimes they can't get on the trial because if you've had a biopsy in the past, like this case, you're ineligible for the trial. But it's expensive, isn't it, doing all this sorts of imaging? And I'm sure a question I would have for you, Professor Zeng, is like, both your centers are offering MR, but there must be very many areas in China where no way people are getting an MR beforehand. And
I have one more
all
question.
around the world as well. Yeah.
I have one more question for PSMA. Yes, as we all know, in our countries, some of the medical centers wanted to not to do biopsy, just to do some PSMA PET CT. We will find the positive lesions, and then we will diagnose it with the prostate cancer, and we will do the surgery.
So no biopsy. So
my question is, do you agree with this?
So this is really interesting topic, isn't it?
Yeah.
And I'll just tell a story for the listeners. I remember coming to this meeting here about 5 years ago, and we were showing some of these nice PET scans. And I said, no, this question arises, and there was a suggestion that if you have double positive imaging, PIRADS 5, big PSMA lesion, could you just go straight to treatment? And I remember a colleague here in China came up to me afterwards, this is 2019, and said, yeah, we've done that in 75 patients. And they've reported it since. It's just been published in JRL. So my view is it's very interesting. And the data we have from primary sort of suggests, double positive, they're pretty much all clinically significant cancer. But on the other hand, if you do a biopsy, it might help, I don't know, with nerve sparing, or if you're planning radiotherapy, boosting. So my personal view is, look, a biopsy is pretty safe. We do them all transperineal, so there isn't even a significant sepsis risk. But as I get a bit older, I wonder, what would I do myself? I've got a very strong family history of prostate cancer. If I turn up with a PSA that's concerning, and if I have a PIRADS 5 lesion, would I go and do a PET scan? And, maybe, but I'm not encouraging it. It should be done in a trial. Well, you can. You agree. You don't want a biopsy. You just want nice imaging. But I was that question, though, that I asked about the rest of China, and like the rest of the world. In Australia, we have MRIs now funded since 2018. But in the US, for example, only a minority of people get an MR beforehand. Yeah. So what's the situation in China, out in the regional areas? And
in our hospital,
yeah,
we have PSMA, but we use the PSMA to do the lymph node metastatic staging,
talk about that in a second,
or we just according to the status of the PSMA PET CT to help our surgeon to make decision, do or not to do the lymph node dissection. We would do this.
Because that's the next area we want to move into then. And let's talk a bit about surgery and, the way we're doing surgery. The Chinese robots things comes up again and again. But, let's have a discussion about surgery, radical prostatectomy, technologies, lymph nodes, and pick the brains of our guests.
Yeah. So Declan has we have some episodes to discuss about the Chinese robotic machines. And there are various machines and with different features like the multi-arm or single port and maybe telesurgery, and you see it's a long distance, but the latency is really small.
Tiny,
so a lot of new innovations in this area, and both doctors, they come from different high volume centers in China. You both have many experience with the new Chinese machines, and how do you consider this is an opportunity to think in a different perspective about how we can improve the surgical outcome of our patients? Yeah. So please.
So maybe I'm the youngest one in the role, and I don't have too much experiences. And till now, I have tried 4 types of Chinese platforms of robots.
When you're older, you'll have tried 10 of them. But I'm so but this is amazing for us to listen to this.
They just put the machine in our hospital and we try. So. According to my experience, the Chinese ones, we tried the Medbot from Shanghai, and we tried the Edge.
That's the Toomey robot, the Medbot Toomey.
Yeah, we tried the Edge from Shenzhen.
Yeah,
and the Surui from Beijing.
Surui,
yeah. So they are all like Da Vinci system.
Yeah, they feel like it, and they
feel like the same, and they are progressing every day. Each day when we operate, they will send 2 engineers beside us to guide us how to do the surgery or how to manipulate their machine, and they will collect the questions and issues from their machine, and they will correct the pitfalls, continuously improving each time. So they are growing very fast.
That is just amazing.
And beside this, I think the Chinese platforms are much cheaper.
Yeah, of course, which is why that's the attraction, isn't it? And in Europe and North America, Australia, there are a lot of Da Vinci systems, but there are so many other parts of the world where there are no robotic systems because they've been so expensive. So this is the opportunity: is these systems will turn up in China, but many other countries where Da Vinci systems are very poorly available. And can I ask you about reliability? Are these systems pretty reliable in your view? These are technologies that you will have alarms and we'll have fixes and things, but
the answer is yes.
Yes,
they're reliable
already. Yeah.
Fortunately, our hospital only have Da Vinci.
Okay.
I just try some of the other types of the robotic.
Yeah.
My feeling is just very similar to the youngest doctor.
Yeah.
Yes, the cheaper and reliable. Yeah.
Yeah, but one advantage is that because there is a lot of system and they are trying to test the different, the mechanism and how to make the surgery more smooth and really the doctor-friendly machine, and they have very quick turnaround time. When we have some feedback, they will maybe return like 24 hours and how to improve this. So this is really changes the system very quickly and make the system available to many of the Chinese hospitals. So as we can see, the adoption of these novel machines is really quickly in China, and we will see what we can change to our clinical surgery practice in near future.
It's amazing. And we're going to hopefully see more and more of these systems roll out across the rest of the world. I think it was just starting in 2024, but 2025, 2026, we'll see it. But to listen to your experience is very educational for me. Moving on again, at your conference in Shanghai, lymph node dissection came up again, and we discussed it in a previous podcast with the Chinese colleagues. So what do you think 2025 is going to bring us for pelvic lymph node dissection? The EAU guidelines will be updated soon. Will it make a comeback, having been pushed away last year? You think?
Yes, I think the really point is that whether we will change the outcome, long-term oncological outcome of these kind of the patients. And we see in other types of cancers, like bladder cancer, the lymph node dissection, when we extend the dissection plan, we do not improve the survival of these patients.
You decrease it.
Yes, and another point is that we have still ongoing clinical trial in Germany. They are testing the hypothesis, do no lymph node dissection with some kind of the extended lymph node dissection. And before this kind of multi-central with high statistical power, and before that, I do not think lymph node dissection is a survival benefit interventions in our patients. And so my point is that we are a big fan of the PSMA imaging, and in our clinical practice, we have more than 1,000 patients treated. If the patients were PSMA negative, we do not do lymph node dissection, and the outcome of these patients is really good.
Yeah.
And if the patient's recurrence mostly because of the positive surgical margin or the seminal vesicle invasion, so I really doubt the role of lymph node dissection for survival benefit in the setting of the PSMA imaging. But we are happy to see the opinions from our Chinese colleagues.
In my opinion, I also is a fan of the PSMA PET CT. I mean, in our hospital or in my team, we are just trying to do our decision, do or not to do the lymph node dissection according to the PSMA PET CT.
Okay.
But PSMA PET CT also have its limitation.
Yes.
Because it has very relative higher NPV but lower sensitivity.
Yeah.
So how to increase the sensitivity is a big problem. If we can solve this problem, maybe PSMA PET CT could replace the nanogram. But right now, maybe nanogram combined PSMA PET CT would give us a very good solution to avoid unnecessary lymph node dissection population, because this kind of population may be very huge.
Huge.
Yeah,
It would
I
have been in
think
the
very
old days.
huge.
If you follow the old nomograms, and they're saying greater than 5% or 7%, well then yes, but 93% of those patients will have an completely unnecessary lymph node dissection, and the other 5 or 7% who have it, there's really no evidence they benefit.
Yeah.
So that's why it's retreating.
And one more thing is because in the past 10 years or 20 years, there are so many new drugs to use in the prostate cancer patients. Just now I read clinical trials with radiotherapy, and that kind of radiotherapy is just to divide patient into 4 groups. One is just a radiation for prostate bed, and the other is radiation for prostate bed and lymph node drainage region, and the third is prostate cancer, prostate bed radiation plus ADT, and the last one is radiation for the pelvic and prostate bed plus ADT. And the result is, when we give the patient with prostate bed radiation plus ADT, the efficacy is very similar to radiation for the prostate bed plus lymph node drainage regions. So I just consideration if we just as a surgeon, if the patient just do the prostatectomy without lymph node dissection, but after the surgery we give the patient maybe short-term or long-term ADT treatment, the oncological outcome could just similar to the lymph node dissection, because lymph node dissection will just prolong the surgical times and increase the operative complications. So.
Wow, seems like not a much, at least in this group here, not a lot of enthusiasm for doing lymph node dissection. We'll see. Yeah, but moving on then to metastatic disease, the other big area we want to talk about, lots of changes. Why don't you take us through, what we see in 2025 for metastatic prostate cancer here in China?
Yeah. So in China, we are fortunate to have most of the anti-androgen available reimbursement in our system, and we are more likely to use optimal treatment, just Axel mentioned, instead of the ADT alone.
Yeah.
And the point is that we do have some concern about the triple or doublet treatment, and we have some patients nearly more than 75 years old. So I would like to listen to my two colleagues' experience. How do you consider the Chinese population? Maybe they have low BMI and old age. So what's your preferred treatment approach in this kind of patient, doublet or triplet treatment?
So I've been doing the systemic therapy for late stage patient about 4 or 5 years ago, and I'm not against the triplet. So the reason why I gave a patient doublet or triplet is according to the tumor volume. I think the patient, for example, for metastatic hormone sensitive patient, the patient group with very small volume, they compare to the patient with very high tumor volume, they are different. They progress in different pace. So I tend to give the high volume patient triplet, but the Chinese population is quite different from the European or Western people. According to my experience, if we give the patient the standard dose of chemotherapy according to the formula, and to the Chinese people, they will have maybe more side effect. So I always change or reduce the dose according to the patient's reaction after the first cycle. Maybe I think 80% of the standard dose is perfect for Chinese people. So
That's a really important point, isn't it? Because when all the enthusiasm for docetaxel came out after Charted, Asia Pacific region puts its hand up to saying, well, hang on, you are aware that the Asian men may have higher toxicity with this, and we wrote about it in the APCCC Asia Pacific paper, didn't we, a couple of times? So that's a very pragmatic description, I think, of your approach to those patients. But I still, regular listeners and viewers will know I keep banging on about my lack of enthusiasm for docetaxel in the hormone-sensitive space, and for the vast majority of patients. But Chinese urologists are very comfortable using systemic treatment, of course, aren't they? But do you feel that we'll be using the same amount of docetaxel in the future, or with the widespread availability of RPs, will there be more doublets?
In my opinion, in our hospital, Dr. Zhu Yao knows, we will do lots of things, not only just to evaluate the tumor volumes. So in some high selective patients, we will use the triplet, such as the high volume or high risk, or with some molecular features such as P10 loss, RB1 loss, or TP53 loss, or the very special histopathological types such as the intraductal carcinoma or other new endocrine differentiations. We will use the triplet, and usually if the patient is just a very classic or very popular types of the metastatic prostate cancer, maybe ADT plus NHT is enough
for me.
So they are all very nice points, and I think the risk profile of the patients and his tumor, and also the tolerability of the treatment in like 1 cycle or 2 cycles are really informative to make an optimal decision for this kind of patient. But at least ADT alone is not will not benefit for this kind of patients with metastatic disease. Yeah.
The last area I wanted to talk to you about reminds me of when I first visited your center, Fudan University Shanghai Cancer Center, 10 years ago, and we were walking around the building, and I was shown this department with I don't know how many sequencers, and you were talking about sequencing tumors, and there was a huge program running in the hospital 10 years ago. Since that era now, it's become very important in prostate cancer because of PARP inhibition and so on. We're now increasingly having to, go back and find an old TURP specimen or biopsy a bone metastasis to try and see has my patient got a BRCA mutation and so on. So already 10 years ago, I was very, very stunned by the level of precision oncology that was going on. Can you tell us a bit about that and find out a bit about what our colleagues think about precision approaches, specifically genomic testing to find these BRCA mutations?
Yes, so I think this is just 10 years ago, we have a very nice start to acknowledge the importance of genomic sequencing. Both me, Dr. Zeng, and Dr. Yan, we are aware of this kind of the importance of BRCA mutation, and we read the paper BRCA mutation with IDCP. You just have right in the European urology, and he is a guy, big fan and a big expert of IDCP, and most of my efforts put on the BRCA mutation, and we have strong collaboration to publish some paper with the genomic sequencing of Chinese patients and to define the genomic background of our patient. And I do believe the genomic selection will aid us to guide the treatment selection and the treatment optimization for our patients. And the underlying question is, how can we use this genomic information to guide the treatment instead of only the west and the east, because it's only the region but not the biology driven of these kind of patients. And I would like to hear your comments. And
Yeah, maybe in the past 10 years, I just concentrated on the genetic testing for prostate cancer, because just now Dr. Zhu Yao said, in our hospital we are always focused on the very special histopathological types of the prostate cancer. So as you know, intraductal carcinoma of prostate cancer or ductal prostate cancer or even NEPC maybe have a very high possibility to with all kinds of the genetic mutations. And my what I worry about is if we do the genetic testing, we find the target gene mutations, but now maybe we cannot find a very suitable target therapy for this kind of patients. Till now, we only have the PARP inhibitors or AKT inhibitors to find some of the patients could get some survival benefit from this kind of target therapy. So the following things we need to do is maybe we should improve our research about the target or some of the novel agents to do the following things. That's
you mean the druggable targets.
Yeah.
So just like Dr. Zeng says, we are putting our intention into sequencing results for many years, but we don't have much choice of selecting a therapy. We look at the RB1 and P53 and P10. So if anyone is positive, we'll try to do chemotherapy or maybe cisplatin regimen. And but except this, we only have PARP inhibitor or AKT inhibitor. According to ESMO presentation this year, like new drugs B7H3 or T-cell engager or DLL, they don't have to do the sequencing. So I think we are at an age we have to learn. We have to learn more about sequencing.
One of the regional challenges we see is that two challenges. One is, when you're looking for that archival tissue, sometimes it is from a specimen many years ago. There's a high failure rate on just processing the tissue. And the second is the expertise, the molecular labs to do it. That's certainly a limitation in many parts of the world. I think for the second question, there seems to be a lot of access to sequencing here in, certainly in big centers in China. Would you say that that's the case? You can get specimens sequenced, but the other issue of 20% of 20% success rate, 20-30%, you know. So a message I think for us urologists is, well, get good specimens, you know, get good TURs, do prostate biopsies on your metastatic patients, because in 7 years' time, you're going to be challenged with, that patient, does he have a BRCA mutation? And, we didn't bother with the biopsy back then, we just put him on ADT and an RP. So I think it's important we do try and get good specimens. What do you think?
Yeah, so this is just a point I learned from Peter Mark, because I joined Peter Mark MDT discussing and invited by Declan. And I see a lot of patients, they have discordant tumor in the PSMA and FDG PET, which is suspicious of metastasis, but we cannot definitive answer this is a tumor or some benign condition. And you just mentioned biopsy disease. And I was really concerned how to biopsy, because it's really small. And that is, your guys told me that if the MTT team is trying to define a new approach, you have to train your team to biopsy these lesions. And after 1 year or 2 years, you will get a very high successful rate for tumor biopsy. So this is the meaning. Yeah. It's the meaning of the MTT discussing and the cooperation. So this is what we have done in our center, because we have recruited medical oncologists to engage with the clinical trial with the company to define the outcome for these patients with molecular alteration, and we are trying to biopsy nearly all the mCRPC patients with visceral or soft tissue tumor to get the genomic sequencing tissue. So this is really helpful to make the treatment really accurate.
Well, there you go. I really enjoyed that discussion. Looking forward to 2025 and beyond from sitting here in China, talking to our Chinese colleagues about prostate cancer. Thanks very much to you, Yao Zhu, our ongoing China editor, for your support and for putting together this great discussion today.
Thank you, Declan, for joining us in Shanghai, and we are looking forward to welcome you and our Chinese colleagues in the near future. And we're really honored to have GUcast in this place. Thank you again.
And thanks very much to our gold partners, Bayer China, who support the podcast and particularly support us trying to bring these dedicated episodes to all our Chinese friends. And special thanks for hosting us in this beautiful studio they've built for us here in Shanghai today, and to the team for looking after us. We'll be back soon again with some more great podcasts. Thank you very much.